we're going to look at solitary nodules and masses and try to figure out your biggest things is benign versus a malignant, okay? But really, I'm not so focused on X-ray of benign versus malignant. That's going to be hard for you guys to tell. What we're going to teach you here in this section mostly is the bronchogenic carcinomas. So I want you to be able to, based off of symptomology and where the mass is on the X-ray, give me when we're talking about a most likely type of cancer or mass that we're going to look at, okay? Most likely. You can't know for sure until you get the biopsy, but if you have a question academically, you can come up with a most likely answer in that aspect. So, I do not need you to memorize the centimeter stuff, okay? This is all things that help you when you get out in clinic to go, hey, do we think it's benign? Do we think it's not? Do we call it a nodule? Do we call it a mass? You know, that kind of thing. So the book definition of a nodule is something that's less than 3 centimeters. Well, how am I going to measure that? Well, you can measure it yourself. What's going to happen is the radiologist is going to tell you, hey, solitary nodule measuring at 3.5 centimeters, or usually they like to use millimeters, so like 35 millimeters. And that will tell you, hey, do I call it a nodule? Do I call it a mass? What is that kind of terminology there based off of size? You will probably get into nodules and masses more in pulmonology, right, and what those sizes indicate. I'm not going to try to pimp you on size for nodules and masses. When we get to blebs and bullaes, those are important, but nodules and masses, I'm not going to mess with you on size. Benign versus malignant, right? So nodule size, the smaller it is, the more likely it's benign, right? The smaller it is, the more likely it's benign. If it's calcified, if it's a calcified mass, the more likely that it's probably a malignant mass. I'm just giving you a map, right? Just so you have an idea. Margins. We talked about this with ultrasound and other stuff, right? Smooth margins a lot of times can be benign. Spiculated, funky margins can be malignant. And change in size over time. That's a big one. How fast is it growing? So what you're going to see when you're in clinic, when you're taking care of patients or you're following up on patients, is some patients are going to have serial x-rays. I.e., we get a small mass on there or a nodule, and we're like, we're not really sure what it is. The patient's not having any kinds of crazy symptoms. I'm just going to go stick a needle in there and biopsy every single nodule or a small mass that I see. That's a bit excessive, especially if they're not symptomatic. But the answer may be, hey, we see a 2 centimeter nodule on there. It wasn't there before. And before meaning maybe they never had a chest x-ray before, or maybe it was like years ago, not really sure what it is. Get serial chest x-rays, i.e. say in 6 months or 3 months or whatever, or a year, depending on what the radiologist recommends. Come back and get another x-ray. And then we're going to measure if it's growing or not and how fast it's growing. The faster it grows, the more concerned that it's a cancer or malignancy. You'll learn more about that in Paul. Okay, we talked about that, talked about the change in size over time, comparing it to previous studies. Yeah. Numbers are FYI. Here it is again, right? This is for you in clinic. I'm not going to test you on this, but this is important for you in clinic. What do I order and when do I order for my patients? When you're the one who is the first person to find the nodule based off of the size. See how it's in millimeters, right? Because nodules are what we're talking about here. If it ends up being larger than 3 centimeters and it's a mass, we're doing further evaluation, right? All the small guys, the nodules, when are we doing stuff and what are we ordering? File this away in your phase 2 folder, your clinical folder, so that way you know how to manage. I'm going to tell you right now, if you are in phase 2 and you're reviewing a chest x-ray on a patient you're going to see, whatever the rotation, internal medicine, family practice, ER, whatever the case is, and you go and look at it, and you're going to have time to kind of like flip through before you go give your presentation to your preceptor on some key things to help formulate your plan, your treatment, that kind of thing. If you roll in with this, you're going to earn a lot of points right off the get-go as a PA student, right? If you're able to roll in and be like, yeah, look at the chest x-ray they had, like in the ER, they have a 5 millimeter nodule based off of the cancer risk and stuff like that. You're going to learn in pulmonology and HEMONC, right? They're low risk, so they just need to do a 12-month follow-up chest x-ray. We'll recommend that to the PCN, that kind of thing. They're going to be really impressed with that because as a student level, they don't expect that right out the get-go for this kind of a follow-up. So file that slide away for that. I'm not going to hit you up on time frames and what to order for these things. Why do you care about these things? All of that is to give you prep materials because you don't want to miss a bronchogenic carcinoma, right? That's what we don't want to miss. So, most common fatal malignancy in men, second most common fatal malignancy in females, right? Fatal malignancy. In other words, a lot of patients die from these things, right? So, what are the main symptoms? Hemoptysis, what does that mean? Coughing up blood, right? Weight loss, hoarseness. Hoarseness that hasn't been there before, okay? So if you have a large mass and you end up having these symptoms, malignancy is increasing, okay, by a lot. All right, increased by over 50% in men over 50, right? The biggest thing is these symptoms, hemoptysis, weight loss, and hoarseness. How do we see it? Well, there are 4 different types we're going to talk about. Squamous cell, adenocarcinoma, small cell, which includes oat cell, right, it goes together, and large cell, all right? So they'll have direct extension or metastatic lesions sometimes, but a lot of what we're going to see is direct extension off of the different areas of the bronchial tree or within the lung tissue, and that's what we're going to look at here, all right? Secondary effects of the tumor, it depends on what else is going on. Can it cause atelectasis? Yeah, right? That compression atelectasis, because there's a mass sitting there compressing on the airways. So we can have atelectasis that goes along with it. Can we have pneumonitis or some type of fluid going on? Yeah, because if we have cancer, we can have inflammation, which can then cause fluid, right? And so we can still have other abnormalities on the chest x-ray outside of just the mass. Well, let's talk about the first one, squamous cell. Primarily central in location. Oh, we're going to play this game again. There we go. Primarily central in location, okay? Comes off of the segmental or lobar bronchi. These things grow rapidly. I want you to notice kind of where it's at and also notice how it's causing that atelectasis as well. So what's happening here is the compression is happening where the mass is, and then the collapse is happening in the airways that are distal to where the mass is, right? So the compression atelectasis is starting where the mass is and then happening out here. So we have that compression atelectasis sitting right here, but then the mass is sitting right here on that lobar or segmental bronchi, okay? Bronchial obstruction, compression, obstruction, I don't want to look at that, either one of those is possible with the atelectasis, right, is most commonly caused by the squamous cell carcinoma, right? This is coming, and look at the picture I have right here. It's coming right off of that main bronchi. Main lobar bronchi. So notice that it's central in location, right? I almost kind of have like, where's my ascending aorta? It's kind of hard to see my spine here. I almost kind of have a silhouette sign there in a way, but it's right up against the spine and it's in a central location. All right? So if we see this, our initial study is obviously chest x-ray. We've done that. What's the next thing we're going to do? CT. Right? CT to further delineate and confirm what the mass is, the size of it, what it looks like, you know, all that kind of stuff. And then once we've confirmed that and we got that, yeah, there's the biopsy in between, but this is an imaging course, right? Then we've confirmed it's a cancer. The next imaging is the PET scan. So remember, chest x-ray is your initial study. Your study of choice to evaluate the lung mass is CT, okay? CT, preferably with contrast, because I need to know if it's absorbing any of that contrast, how much blood flow is going to that mass. Then once I confirm it's a carcinoma, we go to the PET CT to look for metastases and things like that. Does that follow? Okay. Questions on the squamous cell? You'll see as we get to the other ones how you'll kind of be able to sort through some of these other guys. Next one is adenocarcinoma. Solitary lesion on the peripheral, right? Not centrally located. Not centrally located. It's not there. We're on the peripheral. Okay, here it is on this picture. Typically solitary. You can have multiple nodules, but they're still going to be kind of on their own. So like one here maybe, one over here. So you can have multiple adenocarcinomas, but they're going to be on the peripheral. They're going to be separated from one another. These are the slowest growing, of the 4 that we're going to talk about. Okay? These are the slowest growing. Thick wall, nodular, irregular inner margins. So again, here's where you see the irregular inner margins, right? You see that more on the CT. Notice how that's kind of spiculated here. It's not all smooth and easy to kind of, be like, oh, well, that's a little cyst there. And then here we have another one here. So you're gonna say, well, that's more centralized. Well, it's not. I don't have it attached to anything along the airways or the main airways there. It's still a separate nodule in that area. That one is harder to see, but if I give you symptoms of hemoptysis, shortness of breath, right? Hemoptysis, you'd be thinking cancer, especially unless they're like, hemoptysis, be concerned about cancer, especially if they don't have any flu-like symptoms, right? Is it possible to be coughing up and having some hemoptysis if we've been sick for about a week and we're constantly draining, hacking up stuff, sore throat, all that? Yeah, because we can break some small blood vessels and capillaries in there, have some streak sputum. That's not abnormal, right? But if I'm not sick, if I've been sick for 4 or 5 days and just constantly coughing, congestion, all of that stuff, and I'm having hemoptysis, that's a concern for cancer, especially if there's any kind of weight loss going on as well with that unexplained weight loss. So again, your adenocarcinomas are going to be peripheral, okay? They can be large or small, but they are just slow growing. All right, this guy, small cell, including oat cell. Not only is this primarily central in location, you're going to say, okay, great. The squamous cell was central in location too. How the heck do I tell the difference in that? Well, I'm going to show you here in a second. First, on this picture, you notice how the squamous cell kind of came off of this area here, right? Right off of the lobar or segmental bronchi. This is more superior, and it comes up, okay? Which means it leads to some of the symptoms. So we'll jump down before I do the second bullet. We'll jump down to the common symptoms, right? A couple of ones in here. Slurred speech, right? Where's my hoarseness? Difficulty swallowing, okay? Let's see. Sleep disturbances, dizziness. So we'll look at some of those things, right? Why am I having difficulty swallowing and some slurred speech? Because that carcinoma could be getting up into, pressing up on the esophagus, getting up into the vocal cords, causing more of a hoarseness because now it's kind of getting up there. They can start talking like this a little bit. They're not, my voice has changed. I've been really hoarse lately, but I don't have a sore throat. What's going on, okay? The other thing with these symptoms, and I know you haven't learned it yet, you're going to learn it in endo, but SIADH. So what happens with these small cell carcinomas is they start releasing antidiuretic hormone, right? Or calcium. And so what happens is your patient is going to start having symptoms when you learn it of SIADH, of either high calcium or it's going to look like a lot of these symptoms down here. And it's not because they have SIADH, okay? It's not because they have that or they don't have Cushing's. It's because of the hormones and that the cancer is releasing. So what does that mean for you guys? You're going to get patients that are going to roll in when you learn it in endo, and they're going to start talking about their symptoms. They may not even be having a cough or anything like that, but they're just going to talk to you about your symptoms, and you're going to be like, oh man, I think this is Cushing's or SIADH. Awesome, you may be right. Get a chest x-ray. Because if you don't, you might be missing a small cell or cell carcinoma that is making the patient mimic that disease process that you're going to learn about, and you'll misdiagnose just because you didn't just look just to make sure, okay? But for this one, instead of just hemoptysis and weight loss, right, look at the common symptoms below. Focus on the symptoms. If you have a patient with a centralized lesion, and we're thinking possible cancer, and they're having things like seizures, sleep disturbances, either difficulty swallowing, loss of muscle tone, slurred speech, dizziness, vertigo, those kinds of things. Those are your hints to go, I'm thinking small cell instead of squamous cell. Okay? Then you can use your image as adjunct because my cancer is more up, it's not necessarily on here, but it's more superior, right? And it's kind of infringing up into this area here and it's centralized. But again, the last picture we looked at, you were like, hey, you just showed me a squamous cell which had an atelectasis. How do I tell the difference between these two things? Symptoms. Symptoms. Will you be right in clinic? I don't know. Maybe you'll be wrong, right? But what's the next step regardless? a CT, and then when you confirm it's a malignancy, then what? A biopsy, right, in clinic, a biopsy, and that's what's gonna tell you what type of cancer it is, right? So you can have hey, I suspect small cell, go through the process, and if it ends up being squamous cell, great, whatever, they're still gonna get the right treatment. You did the right stepwise process. But you had that suspicion based off of the symptoms of what's going on, so. There's another one. This one's playing tricks, right? It's not as high up, it's more lower, but how would you tell that difference? You would tell it based off of the symptoms. This is the only one of the four we're talking about that has symptoms besides hemoptysis, weight loss, and just general hoarseness, right? It has all the other stuff as well that could be happening with that patient. Finally, large cell carcinoma. Another peripheral one, much larger. Okay? The difference between this one and the adenocarcinoma. Does anybody see it in the bullets? Growth. Large cell carcinoma grows very quickly. Adenocarcinoma is your slowest growing. So, patient history, timeline, right? What was the nodule? What does it look like now? Right? Is it growing rapidly? Is it slow growing? I would hope, in most patients, that if you were tracking an adenocarcinoma, you would definitely be researching it much longer or much sooner than it takes to get to this size. Okay? How could you tell that's a cancer just based off of the image and not a large cyst? What would I have if it was a cyst? Air fluid levels, right? Somewhere in here I would have air and fluid, and I would have that air fluid level. I do not. This is a solid mass, because there will be large cysts that may look like this, but it has an air fluid level. That's going to be how you distinguish between a mass or a cyst, okay? But this one is your large cell carcinoma, still peripheral, not central. It's small, but notice how I kind of have a little bit of healthy lung tissue kind of in between my central structures and my carcinoma. But then on top of that, it's up against the edge of the wall here. It's more peripheral, and again, rapidly. So, my central lesions, I have my squamous cell, I have my small cell / oat cell. Those are kind of one and the same when we're talking about it. One of them is going to be standard hemoptysis. One of them has all those other symptoms. We tell the difference, those are central lesions. My peripheral lesions are my adenocarcinoma and my large cell. And the biggest thing besides size on that one is going to be growth speed. Slow growth speed versus rapid growth speed. Questions? Okay. So, if you had a 68-year-old smoker with a history of a mass on a chest x-ray that they were scared to follow up on, because that's what they do, come back in 6 months. No, I don't want to know what's getting bigger. You order the chest x-ray and compare it to the note, and you notice that there has been little growth compared to the last one. What's your working diagnosis? Adenocarcinoma. Anybody able to pull that out? Right. Everybody notice a small little bit of parabronchial cuffing there? Good. All right, all that means is there's fluid around the bronchioles. Doesn't necessarily mean CHF yet. I would need more stuff. It's an abnormal finding, right? So, okay. Now if I have a 68-year-old male with a history of smoking has a solitary lesion that is 9 millimeters in diameter, lobulated on CT, and has appeared since its last x-ray 9 months ago. The patient wants to know what the chances are that it's bad cancer. What do you tell them? So what we're looking at is 9 months ago, nothing, and now I have almost a 1 centimeter mass. What are the odds this is malignant? Pretty high, right? That's pretty quick. To go from nothing to a centimeter in less than a year, that's not good. So the answer is, sorry, man. You find a better way to do that, right? You say, well, it could be, wait till we do the full evaluation, don't worry. Meanwhile, in your head, you're like, oh, shit. But the good news is, right, you turn on, but the good news is, it's still less than a centimeter, so hopefully we've caught it early enough. Let's get the biopsy, or let's get the CT and then the biopsy and figure out what's going on, and we'll adjust from there, right? You can always try to put some kind of a positive spin, even on bad news, right? Even on bad news, to try to make it less daunting. Hopefully in your spring course you'll get some practice giving bad news to patients because it's gonna happen. All right. 76-year-old male smoker with hemoptysis, shortness of breath going on for the past few weeks. You order a chest x-ray, you notice some upper lobe atelectasis, just hemoptysis and shortness of breath, so what are we thinking? Squamous cell, right? You don't have those other symptoms for you to lead you towards small cell or oat cell. Mass is right here, and then there's my atelectasis. Kind of a pentagon, so you can talk about that. And yes, for those that are looking, this is an enlarged, looks like an enlarged potential aorta there, or it could be a mass. I don't know which one, right? I need more symptoms, but there is an abnormality here. Heart is too close for me to ask you to pull out cardiomegaly, right? So I wouldn't ask you to pull that out. No costophenic angle blunting. Yeah, pretty much just the cancer there. All right. What about this one? I am likely not going to say recently diagnosed with SIADH because I just word associating. I'm going to give you some of those symptoms if I want you to pull this out. Okay? But because I just put all that and just hammered that, that's going to be your small cell. And then finally, it's the same picture we just looked at. Here's an example of a large cell and vignettes that are going to be similar to what you could see on the exam. Yes, sir. It's a cancer. That's outside of my, right? So it's a type of cancer. I don't remember off the top of my head why they call it oat cell carcinoma, to be honest with you. I'm sure there's a pathology reason of why it's called that. I can look it up and get back to you. Make a note of that. I'll look it up and get back to you. Questions on the cancers? Okay. Okay. Write those down. Good. Thromboembolic disease. Right? Thromboembolic disease, clots. For lack of a better word, clots. Usually occurs after 60 years of age. Age is not a disqualifier though. Okay? I'm just telling you commonly, do not let the age of a patient deter you away from thinking there's a thromboembolic disease process going on if everything else screams there's a thromboembolic disease process going on. Okay? Most common cause is going to be a deep vein thrombosis of the lower extremity. That's typically in the calf. All right? We hear that all the time as far as, hey, if you ever go on long plane rides overseas, get up, walk around, stretch, that kind of thing. Long car rides. There are other things that increase the risk factor, any type of immobilization or surgery. Why? Because if you're immobilized, blood can kind of sit there in the veins, it doesn't flow, and can clot up. Same thing with surgery, there's inflammatory processes that can lead to clotting, and then again, if we're not moving around, which typically you're not after surgery, that can increase the risk. There's other things that are going to increase the risk, particularly smokers increase your risk of clotting diseases, the thromboembolic diseases. Pregnancy increases the risk. Birth control pills increases the risk. This is why I don't know where they teach this in pharm yet. Have you guys done birth control stuff yet? No? Hormone replacement therapy? Okay. That's why you're going to learn for women. A lot of women here already know this, or should if they've had good providers. When you hit 35 years old, when women hit 35 years old, 35 and older and smokers do not give birth control pills. That is way too many risk factors for causing clots. Right? So then you go, you're already older than 35, so you're starting to get up there as far as clotting stuff goes. But then you're a smoker, which increases your risk factor for clots. And then I'm going to give you a birth control pill for birth control, obviously, or for menses. When people are going through perimenopause, right? They want to control their menses a little bit more. They start losing the estrogen. They're getting like the hot flashes. You can give birth control pills to help out with those symptoms, but don't. Because, especially if they're a smoker, because you increase their risk of developing a deep vein thrombosis or a clot. Okay? You'll learn that in pharm, you'll learn that in women's health. But here's all of the risk factors of having a thromboembolic disease. Really, mostly what we're talking about here, DVTs and PEs, pulmonary embolism. That's what we're going to focus on. Okay? So, these are all the risk factors. Yeah, obesity is a risk factor, cancer is a risk factor. Familial disorders, I'm not going to hit you on these factor 5 Leidens, yada, 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 but you will see them again in other courses. But I'm not going to throw that in there as a history for you for this course. It's going to be all these other ones, right? And it's probably going to be like at least 2 of them, or maybe even 3 of them, trying to tell you what I'm looking for, what I want you to go for, okay? How do we assess that? So yes, chest x-rays in yellow, right? Sure, we're always gonna do initial with the chest x-ray. Always, always, always. How often do you think we find a clot in the pulmonary vasculature on a chest x-ray? Almost never, right? There are two signs that we are gonna learn about, that I'm going to teach you, that you will never see. But it's in the book, and they are great board questions, right? They don't give you a chest x-ray, but they'll be like, chest x-ray shows a Hampton's hump. You're like, what the hell is a Hampton's hump? Well, we're gonna talk about it, and you need to know that that is a concern and a late x-ray finding for a possible pulmonary embolism, right? Because they're gonna be on the boards. You'll never see them. Okay. The true way to assess for somebody who we're concerned about pulmonary embolism, if we can, is a CTPA or a CT with contrast or a CT angiography. There's 8,000 names out there for it. But the bottom line is I need to pump that pulmonary artery full of contrast so I can see if there are clots in the pulmonary vasculature. Okay? So a CT with contrast. Or a VQ scan if they can't have the contrast or a CT. Okay? Or a VQ scan if they can't have the contrast. Okay. If there's leg pain and chest symptoms, we'll get to this, right? We have algorithms, we'll get to it. If there's leg pain and chest symptoms, you can do an ultrasound to look for a DVT, deep vein thrombosis, to help make your diagnosis and just start treating in certain cases. And you don't need to necessarily get the CT in certain cases. We have multiple algorithms. Here's one of them. Okay, do not worry about the low probability, the intermediate probability, or the high probability, the Wells score. You will learn about the Wells score in another class. I have circled the part that I want you to focus on right now. Okay? CTPA, that is your primary. I want you to look at the title of this slide. It's for who? Non-pregnant patients. Which means all males, right? And women who are not pregnant. You are going to get a CT, pulmonary angiography, if it's feasible. When would it not be feasible in a male? If they're unstable, okay? What's another reason it's not feasible in a male? If they're allergic to the contrast, right? Then we jump down to the ventilation perfusion or the VQ scan. Okay? If they're allergic, if they have well-controlled diabetes, just tell them to stop their meds. But this is why, all right. This is why that question's in the first block, right? Because, I'm glad you said it. There's a virus. I told you I gotta fix the question, right? This is why that question's in the first block and why I need to change the question, right? And I need to change it to outpatient family practice. Because none of you in here are wrong with that. If this patient walks in and you're concerned about pulmonary embolism and they have well-controlled diabetes and they're taking nephrotoxic medications, I don't care. I'm giving them contrast because this can kill them today, right? I can always, if I have to, and that's a risk-benefit ratio thing, right? I can give them the contrast, admit them afterwards, flush the crap out of them with fluid overload to help flush the kidneys via IV fluids, right, for a couple of days to help save the kidneys. But if I miss this, they could die, and pretty quickly, right? I don't know if I told this class. Did I tell this class about when I was an X-ray tech about the surgeon who came in? No? Okay, I didn't think so. So when I was an X-ray tech, before I became a PA, I worked at Travis Air Force Base. I was working in the ER on night shift, and we had one of our surgeons who we knew very well, who I worked with in surgery, doing all kinds of hip replacements and stuff like that. And he had recently had a very simple procedure, very simple surgery, very low risk. I was in the ER working, he was at home. His wife called into the ER and was like, hey, Jim's having some pain in his leg, he's got some redness in his leg, or that kind of thing. So we're bringing him in, just want to let you know we're coming in so you guys can get a bed ready for us. We're like, okay, cool, bring him on in. It was actually in his quad as opposed to his calf, but calf is more common for these clots. But he noticed he was having a little bit of pain, he started to have some redness. What happened was he developed a clot in his quad from the surgery, right? Surgery and mobilization, risk factors for possible clots. She brought him to the ER. They were wheeling him into the wheelchair. We had his bed for him, and they're like, "Hey, get ready for an X-ray, so we can make sure we get a chest X-ray, and we'll get a leg X-ray just to see if there's something going on with the surgery, that kind of thing." And so I have my machine all ready and stuff like that. And wife is rolling him in. He's like, "Hey guys, I'm sure it's absolutely nothing, but we really just wanted to make." Eyes rolled in the back of his head, and he passed out mid-sentence. Threw him on the bed, started CPR. We're not able to bring him back. What happened was he had a clot in his leg. It broke off, went into his pulmonary artery, lodged. He had a PE, and it killed him like that. So we'll give the contrast if they have uncontrolled diabetes, which is why I need to change that question, right? And that was really what the conversation was. But this is real. And so that's where that risk-benefit ratio comes in. It's the first patient I ever saw die, but I was only like an A1C at the time, so it was pretty rough. But these are the kinds of things that can happen in medicine, right? Nobody did anything wrong. As a matter of fact, everything was done 100% correct. If he wasn't a well-informed medical provider, he probably would have passed away at home. But like he knew what was going on, so they got him in, and it just wasn't fast enough. And sometimes these things can happen. So CTPA if feasible, if not VQ scan, but in all non-pregnant patients, I want you thinking CTPA unless they can't have the contrast. And they can't have the contrast because really they're allergic to it. That's the biggest thing, right? All right. But if they're pregnant, we have a whole different algorithm, right? So let's go over what this means. You suspect a PE in pregnancy. Do they have leg symptoms? That's what it's asking. Leg symptoms is calf pain, okay? Lower extremity pain. That's the symptoms I'm looking for. If they don't, chest x-ray. You can do a chest x-ray on a pregnant patient, no big deal, right? Okay? If it's normal, VQ scan. Why VQ scan? Because I want to get the contrast and do a CT with all that radiation on a pregnant patient. Bless you. If it's abnormal, CTPA. And you're going, whoa, whoa, whoa. Why are we giving contrast with all that radiation if the chest x-ray is abnormal? Because I just told you the two things that we're going to be looking at for a PE are so super rare in chest x-ray that if that x-ray is abnormal for any reason, our risk and concern for PE has skyrocketed up. And it's worth the risk to do the CTPA on that pregnant patient. They will shield the belly. Okay, they will shield baby. It will help save some of the radiation from baby. You might not get the bottoms of the lungs, but we're more concerned about the central area. That's the one that's going to kill her, okay? And that's when you're going to jump to that. Leg symptoms absent, chest x-ray abnormal, CTPA, okay? This is the treatment stuff. I'm not going to ask you about treatment, but you're going to need this for going forward. If you have a patient that you suspect a PE, because I've given you the risk factors, A, she's pregnant, right? Prolonged immobilization could look in a lot of different ways, right? We just PCS'd here to Texas from Delaware, and we drove straight through, right? I just came back from a vacation visiting family over in Europe or Asia, and we had a 15-hour flight coming back. Immobilization can look many different ways. And she's pregnant, and she's having some chest symptoms, and she has leg pain. CUS stands for calf ultrasound. CUS stands for calf ultrasound. Because I'm looking for a deep vein thrombosis. If I see a deep vein thrombosis, I'm treating, right? I have a pregnant person, looks like a PE, smells like a PE, and I have the clot in the calf, which is likely where the PE probably came from. I'm treating, we're done, right? But the key thing that people get tripped up on this slide is leg symptoms present, you do the calf ultrasound. You don't even do a chest x-ray on this patient right now. Get right to the calf ultrasound. That is gonna be your study of choice. And initial. The biggest line is I want you to skip over the chest x-ray. If they're pregnant, you suspect PE, and they have leg symptoms. Go right to the calf ultrasound. Because that'll give you everything you need to know if it's positive. If it's negative, you notice you just come right over here. And we just go right over and we follow down the same normal algorithm, right? Because we're not done yet. Just because it's negative doesn't mean she can't have a PE. Okay? So we kind of shoot right over here. So if you were to get a patient, say, hey, we did this, she had leg symptoms, cap ultrasound was negative, chest x-ray was normal. What's your next study you're gonna do? It's gonna be a VQ scan. Got it written right there too for you guys, of which one is our study of choice based off of the chest x-ray if we get to that point. But we're not always starting here. We start here with the leg symptoms and the PE of pregnancy. All right? Okay. Let's briefly cover these radiographic x-ray abnormalities, right? So Westermark signs, so 75% of patients have PEs, result in a clot, elevated hemidiaphragm, unilateral pleural effusion, your large pulmonary arteries infiltrates. Guys, that's not very specific. We talked about all that stuff in general. That doesn't tell me a dang thing, which is another reason why chest x-rays aren't beneficial, because you're not going to be able to look at it and be like, oh, I see these things, so it's probably a PE. No, right? So don't get hung up on that. There are uncommon findings, okay? Westermark sign and Hampton's hump, and then technically the knuckle sign. All right, Westermark sign. What is a PE? A PE is a blood clot, which means it stops blood from flowing past it. So, Westermark sign is this lovely absence of lung markings or vasculature distal to the blood clot, to the PE. So if you see this, you can be concerned about a PE. 2% of patients, guys. Understand what Westermark sign is, like the pathophys behind it and why it kind of presents the way it does. I'm not giving you a Westermark sign on an x-ray for this exam, but the boards love these kinds of words, right? Beck's triad, what was one called? Dressler syndrome, Westermark sign. Like they love pathognomic words, right? So that's what Westermark sign is, but 2% of patients. Hampton's hump. Oh, look, nice little shallow wedge on the periphery. All right? So when I circle it with a big red circle and then I do this, you look at it, you're like, oh, okay, yeah, I can kind of see that. But when you're actually reading the x-ray, especially probably in an emergency room, in a time of immediate need, because that's where these patients usually come in, I don't get so hung up on that, right? So what's happening is this Hampton's hump is because the PE has been going on for so long in this smaller vessels here, which isn't really going to kill the patient in this area. You can have a small pulmonary embolism in those like really small kind of vasculature down at the end. You're going to get a little bit of chest pain, some shortness of breath, right? So you might see this in that aspect, but it's not going to see it. You're not going to see it really in an emergency setting because it takes time to do that because it represents hemorrhagic and necrotic lung tissue. So think of how long that clot would need to be there for that lung tissue to get necrotic. It's going to take some time. So yes, a Hampton's hump is a sign of a possible small pulmonary embolism. If you ever see it on chest x-ray, the radiologist calls it, good job, order a CTPA, and to really get the full extent of what the damage is. But I'm not going to make you pull that out on x-ray. But I might make you pull it out on CT because you will be reviewing these. So, pulmonary artery, okay? We've looked at the pulmonary artery one a little bit before. We've given it contrast, which means it should be all what color? White. That's clot. So what is happening is the contrast has pushed all of the liquid blood out of the pulmonary artery when they took this picture. So instead of blood being in that pulmonary artery at this exact moment, it's all contrast, which is why you can see it all white, right? It's filled it up, it's pressurized, it's timed just right. And what's left in that gray area, if there's any, that is clot. That is solid blood clot that is attached to the walls of the artery and kind of making a barricade, and that is a pulmonary embolism. You can also get it, so for example, look at this vessel. See how that vessel is completely white? Nice circular white vessel here. I'm going to circle it again, right? I can make out beautiful vessel, nice, big and white. It's all white. But then look at one of my main vascular stems there. I got all this gray in here when I should have a nice, completely white circle. That's another clot. As you scroll through a pulmonary embolism, as you scroll through, you'll be able to trace these guys all the way down through the lungs and follow all the way down and see if there are some small kind of pulmonary embolisms in there, right? You'll get practice in that when you get out to the clinic. If I give you one, it's going to be this slice right here. A very clear picture of the pulmonary artery right? To test whether or not you know what does normal look like versus finding that pulmonary embolism. I'm not going to give it to you and give you a completely normal pulmonary artery and like have like a little gray area right there and be like, oh, you should have seen that PE, guys. I told you about it. It will be in this section if I give it to you. All right? This is something when you're in your ER rotations and you're reviewing CT scans that you will probably be reviewing prior to the radiologist giving you the report. You're going to be scrolling through it and be like, there it is. Let's start treating them, which you'll learn about later. If you can't do a CTPA, you can do a VQ scan. Remember how nuclear medicine studies work. We give the radionuclide and we put them in the scanner and it emits radiation from the stuff from where it's being absorbed at, right? So in this case, we're looking at blood flow. So my normal VQ scan is the completely dark lungs in the shape of the lungs. If I have gaps in those black arrows, that's area that's not getting blood flow because that radionuclide that I just gave to the patient is not getting to those areas of the lungs because the blood is stopped. Right? So it can't get there, so it's not emitting any radiation, so that's why I'm getting gaps in those findings. So that's why this one, the gaps, is the abnormal because there's no blood flow there. Now, where are the pulmonary emboli exactly? I don't know with the VQ scan, but it doesn't matter because I know enough to be able to start treating this patient, and we can worry about that later. Because the reason we did this is because we can't give them either the contrast or the CT is too dangerous because they're pregnant or whatever the case may be based off of the algorithms. Look, it's the algorithm again. Know your algorithms. Does that make sense on why we order, what we order, when we order it, and how? Okay? Good stuff. All right. Ultrasound of lower extremity. Okay. So, this is why we do the ultrasound. This is what's meant to show you whether or not we can have a deep vein thrombosis. So this image is without compression, okay? This is the left common femoral vein. That's what CFV means down there. This is all blood, okay? Are veins compressible or are they not compressible? They are very compressible. So how they test for these things and they look for DVTs is they first find the left, where the area is, where the pain is, left common femoral vein in this patient, right? A lot of times it's going to be one of the calf veins down in here, just depends. And then they compress it. And when they compress it, the entire thing should and kind of close off. When I have an area here that is not fully compressing, it's because there's clot stopping it from compressing. Right? And so there's something solid in there, which is clot, which stops it from compressing. If the entire vein compresses, then it's all liquid blood, they're able to compress it, kind of like this part right here. Like this would be okay, but then I have this really large area that's not compressing here, right? That should be compressing. So that's clot. Now a lot of providers looking at it seriously like, yeah, but isn't that going to risk breaking it off, right? And sending it to the pulmonary artery if we end up compressing on that? Yes, it will. But what happens when you see this on a pregnant patient? You're treating them anyways, right? You're going to get them on, antithrombolytics. I can't say it, but things to stop clotting, medicines that stop clotting. Okay, you're going to get them on these medications. So yes, it's a risk, but especially if it's a pregnant woman, it's less of a risk than throwing them through the CT scanner. Because if it's negative, you go through the process. But if it's positive, you're done. You give it no radiation, no contrast, and you can treat the patient and get them admitted. But that's why we do that. Whew. Last one to pass real quick. What's that called? Okay. What else do we see on this one? Yeah, continuous diaphragm sign. So if I have continuous diaphragm sign and subcutaneous emphysema, what's our most likely diagnosis? Pneumomediastinum, right? If I had continuous diaphragm and I didn't have subcutaneous emphysema, really hard for me to kind of find where the great vessels are versus that, I would probably go pneumopericardium. Now, Do they have a pneumothorax? Let's take a look. I don't see one. I have scapula. I don't see a pneumothorax here. Kind of not the greatest image in the world, right? To look for a pneumothorax, I'll admit that, but it is a good image for subcutaneous emphysema and continuous diaphragm sign. Okay. You just saw this picture. Squamous cell, I should give you symptoms, but just showing you that picture again. And here's what the question would be with that last image, right? 45-year-old urgent care, complains of cough and flurry of chest pain worsening over several weeks. Chest x-ray notes central lesion with segmental atelectasis, consistent with what type of cancer? Squamous cell. 72-year-old male, ED, left hip fracture requiring surgical fixation, returns to new shortness of breath and flurry of chest pain. Chest x-ray shows an elevated right hemidiaphragm and infiltrates, right? That's there in case you memorize all that other stuff, but really the rest tells you what you need to know. What are you concerned about, and what 2 studies are possible to order for this patient? CT with contrast, or not an ultrasound that was only on your pregnant females who have leg pain. VQ scan, depending on whether or not they can have the contrast. So those are the 2 you're thinking of, because a 72-year-old male. Even if it's a 72-year-old female, probably not pregnant, guys. But I'll make it clear whether they're pregnant or not. Just based off of location, what do you think that is? Adenocarcinoma. Questions on that guy there? Sir?
Might be a stupid question.
No such thing. Go.
With the female algorithm.
Yeah.
Why do you may have already explained this, but why are we doing the chest x-ray?
Because what if it's not a PE? What if their shortness of breath and chest pain is due to something else? Right? What if it's due to something else? And you may have your answer without having to even spin them through a CT scanner or anything, right? So you have the suspicion of pulmonary embolism, right? So you always, if they're not having the leg pain, you always start with a chest x-ray, period. Always. Because it might be something else going on. Right? What if you see a giant mass, right? Like the carcinoma we talked about. Great, I'm gonna schedule you for a CT, but I don't need to throw it to you right now in the ER. Right? So it's just to make sure we catch everything that we need to catch. And based off of the images, especially in those pregnant patients, right? The CT is more definitive. So what's my risk factor of, do I need to just say screw it and give them the contrast in the CT because I need to know? Or can I do the VQ scan, which is safer, but takes a little bit more time? And that's really where that chest x-ray helps you definitive going, well, okay, chest x-ray is normal, so it doesn't look like there's anything emergent going on here right now, or like a long-term PE. We're going to go and order the VQ scan because it's a safer thing, versus you actually see, say, a Wester's mark sign on the chest x-ray. Oh, holy crap, no, we're pumping the CT scanner because that's a big enough PE to where we're starting to lose that vasculature in that section of the lung. I need to know now, so I need to know if I'm going to treat it or not. Does that answer the question? Okay. Other questions? All right, take 10, come back to the top of the hour.
For that one guy on the team, it's like spot fucking off the street. Just an ad for a differential.
That's the only thing we have.
That's a great diabetes.
Asians like
That's an age.
it's not a lot of website, but we never really go.
I'm gonna order a coil house.
Don't do it. I don't.
You went like all the
We're not, that's just we showed you the algorithm is telling you this. But if they have rates, if you do this is me showing you that it's really open, how to find out if it's in there. This is how outside of like doing some most it's not necessarily more sensitive. If I'm going to give you that, if I just put my lab values in there, I will also put it in this course.
Get a jar and it's so you can put it in the middle. Next time somebody has a side card, they can throw $1 in the jar. I remember something with this. Honestly. Unless you're working 20, dude. I've never seen this before. Yeah. Oh, yeah, bro, I had this man. Wait, I messed up. Let me go back and have a some more.
Oh, is your nail fire? Can you try these green beef sauce chicken nuggets? Okay. So Friday then, I'll bring my stuff back over because like horse.
It's just like dry not even steam, and they'll dump it out and like oh my god, it's Louisiana, and he's like it's like what? What is that?
So did they decide which field it is?
That way, whatever you want. Yeah. Like they $20 a pound right now. No crap.
All right, let's get back started again. Sit down. Yeah, right. So, oat cell carcinoma, Valdez. The reason small cell is called oat cell carcinoma is because when you look at it in pathology, like under a microscope, the cells look like the old school, like Quaker oatmeal things, really flat, kind of oblong out, and the way the nucleus sits, it looks like a piece of oatmeal, dry oatmeal. So that's why they call small cell oat cell carcinoma. There you go. I learned something new. Thank you for asking. I'm like, oh, really? This is like, oh, that's great. So I had a couple of good questions on the break too. I hope you guys saw from my first test, right? It's test questions. I know, like, hey, on the test, how's it gonna be? Not a big factoid guy, right? So I wouldn't expect to see a whole lot of what percent of this is this in percent with 5 percent choices. Right? I feel like the job of this course and all the ologies is to test your clinical acumen and your ability to interpret and then put together a diagnosis. So not a huge factoid guide outside of, you're gonna see a lot like most common or most likely, and that's just medicine, right? And then I told you don't worry about the sizes. And then, what was the other question that was asked? The last one, I was like, I have to say something about that. Lab values, thank you. Lab values, right? We're talking about hypercalcemia and like all these kinds of things. If I give you that, one of two ways it's going to be presented. It's either going to say hypercalcemia as a symptom, because that's what I taught you, or if I give you a lab value, I will give you what the normal range is supposed to be, right? So that way you can look at it and be like, oh, this is normal calcium, and your calcium is higher than normal, that's hypercalcemia. Okay, I do not expect you to know normal ranges for labs, partially because I don't know how far you are in clin lab, right? And partially because you're going to have all of your lab values given to you. Typically, even when you take your boards, they have a little pull down that gives you the normal ranges for all the lab values. So it's important so that way when things are like crazy out, you're like, oh, but in reality, clinically, right, you're going to have those normals available to you. So if I do that, he'll have normal values. Okay, this is the last slideshow of the chest block type area, right? Yay. I keep this in here. This is not my slide. This is my predecessor's slide from when he deployed. I keep it in here because it reminds me to tell you, like, kind of bring it back home for what you guys do, right? You're sitting here. Most of us got paid. I don't see any coasties in here. I think the coasties got paid too, but they didn't get. Rumor has it they're going to. So, I don't know. But anyways, most of us got paid. Yeah. No, hopefully, I don't know. Anyways, why do we do what we do, right? Why are you sitting here having military PAs as opposed to going to a civilian PA school, right? This is why. It's money, yeah, right? But really, this is why. So this here is, I think, in Bagram. He had this up. He was an ERPA that was out there, and this was one of the things that they're wheeling in a third country national right now who got injured. They just even tell the story about how when they would come in and they would go on the stretcher, the first thing they would see is the American flag, and knowing that they were in a safe place, right? And knowing that they were going to take care of it. This pegs me, I wasn't there, but separate story of something, an example like that. It was when I was doing the Operation Allies Welcome, right? I told you how I was reading the chest x-rays for tuberculosis. Well, I worked on many different teams during my 4 months that I was out there doing that. And one of the teams I worked on was the arrival team. So when the plane would come in and hit the tarmac, we would go meet them at the plane. And there were sometimes medical emergencies. I delivered a baby on a plane. She went into labor like as they were landing, and they radioed to us. So we had to get up there and deliver the baby on the plane. Had people pass out on the plane, that kind of thing. But we were there doing med checks as they were coming off to make sure that it was okay. I think I told you guys this one. Anybody been to the desert in New Mexico? Holloman, right? What's it look like? Afghanistan, right? Imagine the looks on these guys' faces when we took them from Afghanistan, told them they're coming to the U.S., flew them to Germany for a pit stop, right? Sometimes stay there for a little while, put them on another plane to the United States, and they land in the high deserts of Alamogordo, Holloman, New Mexico, and they walk off the plane and they look at it. And this was summer, this was August, right? And they just look, and it's 115 degrees, and they see desert and mountains. They thought, no joke, look at these faces, they thought they were being pumped. They thought we turned them around and sent them right back. Until they saw the flags on our arms. And then they saw US on our badges here, right? And then the look of relief on their face coming down the stairs once they realized they weren't back in Afghanistan, right, was something that will stick with me for the rest of my life. First the amusing part in the beginning, but then the actual look of relief of like, we're safe, we're not there, like, this is good. These are some of the things that you guys are going to, I'm gonna say it, listen, deploying sucks, right? Nobody loves being away from family and stuff like that, but I'm gonna say you'll have the privilege to do by being a military PA, and I do think it was that. It was a privilege to do some of the stuff that we do out there. So don't sell yourself short, right? You're here, and there's a reason you can do things that other PAs out in the civilian sector cannot do. None of the people out at Duke University can do the crap that you guys are gonna have to do when you get out here. So, anyways, there's my little stepping stool. All right, so airway medius item, right? More importantly, we're now gonna finally dive into EFAST a little bit. We've been talking about it briefly, but now we're gonna look at it and we're gonna get into when do we do it and what are we looking for, okay? So, when do we do it? Trauma, we talked about it. Trauma. Trauma regularly, trauma in pregnancy, trauma in pediatrics, subacute torso trauma. And if it's trauma, we're probably gonna do an EFAST, okay? Undifferentiated hypotension. Why? Because they're probably bleeding somewhere on the inside, so some sort of trauma. Okay, we're taking care of that, right? What are we looking for? We are trying to find out if there's any abnormalities in or around the abdomen or the heart, right? So we're looking for a pericardial effusion or a hemopericardium. Now here's the problem. I put them both on there because if I see fluid around the pericardium and the heart, I don't know if that's blood or just excess fluid because all fluid looks black on ultrasound, right? So you'll get the subcytoid view. I'll show you what the views look like. We're also going to be looking for a hemoperitoneum or free fluid in the peritoneum. Again, I don't know if it's blood or not with just the ultrasound. So we look in the right upper quadrant between the liver and the kidney. We look in the left upper quadrant between the spleen and the kidney. Then we look at the suprapubic views, which is really between the rectum and bladder in men and between the rectum and the uterus in women. But we're looking at that bladder area to see if there's any fluid around the bladder. And then we can do the pneumothorax, which is the extended fast, those lung views. All right? Here are the areas. You are going to do this your senior semester. You are actually going to do this on one another. You're going to get practice doing this. And I'm telling you, when you get out to your phase 2s, practice on your patients. You now have a full 6-week ER rotation. There is going to be downtime in the ER. You're going to have patients that don't belong in the ER, right? But they came to the ER because the clinic is closed and that their provider had no appointments available. So while they're sitting there waiting forever in the bed because they're not actually emergent, if you don't have any patients, ask your preceptor. A lot of times they'll say yes, and go ask the patient. Hey, I'm a PA student. I came and saw you earlier. We're still waiting on the labs to come back and everything. Do you mind if I just practice doing ultrasound on you for, when trauma patients and stuff come in? And most of your patients will allow you to do it. There's no risk, there's no radiation. They sit there with some gel, and you're just practicing your EFAST, right? So take advantage of that time. Most of your patients will allow you. Some of them are going to be mean and be like, no, get the hell out of here. I just want to go home. Okay, fine. But a lot of times you'll get that chance to practice. So utilize that time. But these are all normal. So here's what we're looking at, right? So right upper quadrant, liver, kidney. So take a look at the kidney, okay? That's your kidney there. Here's my liver. And I have this line right in between it. Can you see this? How the liver and the kidney are basically right up against each other. I have no black fluid line in between the kidney or the liver. They are touching. They are friends, right? That is normal. That is what we want to see. Same thing with the left upper quadrant. Spleen, kidney. Right in between here, I have that. Now what you see here, that's a rib shadow. Okay, because where's the spleen sit? The spleen sits more up in, so that 12th rib might kind of get in the way sometimes. You got to move it around a little bit to try to figure it out. But really, I have the spleen and the kidney are friends. That's normal. Okay? The heart. Subxiphoid view, I have the heart right there. These are my chambers. Here's my septum. Okay? But what I'm looking for is I'm going to circle the area I'm looking for here. I'm looking in here. And I'm looking in here. Do I have any black or any fluid around what is supposed to be the outside of the heart? Because that pericardium sits right on that heart muscle. So I should not have any gap between there, right, that I can see on ultrasound. If I do, then I have fluid in the pericardium, okay? So that's normal. And then here's my suprapubic view, my nice bladder, all contained in the shape of how a bladder should be. I get this lovely posterior acoustic enhancement, because the ultrasounds are coming down through the fluid-filled structure. Okay? Here are my abnormals. Right upper quadrant view, liver, kidney. Look at my black line. They're not friends anymore. There's something separating the two of them. That is a positive EFAST in the right upper quadrant. What is it? I don't know. Likely blood, but I don't know. I can't be definitive about this, right? But I do know that there is fluid in the abdomen that is free, that should not be there. Here's your left upper quadrant. A little bit of a different view, but spleen and kidney, and I have black in between the two. They are not friends. It could look like this as well, in that view as well for the spleen, right? But the biggest thing here is when we look at our normal, right? They are right up against one another. It is abnormal if you have a black line of fluid in between. Here is my heart and my subxiphoid. Here's the edge of my heart here. I can see my valves. Got the edge there. Here's my pericardium. So there's my fluid. So you trace the valves. This is heart muscle, right? Your chambers. Heart muscle, and then I have this line of black fluid outside of the heart, up against the heart muscle. That should not be there. Bladder, right there, right? If I just had this, fine. But why is there fluid sitting right here, right outside of the bladder? Should not be there. Okay? Here is some good links, right, to kind of look at this a little bit more from the EFAS standpoint. That's what I need you to know. I need you to know for right now, not where to put the stupid transducer thing, you'll learn that senior semester. I need you to know by looking at images what is normal and what is abnormal from the EFAS, from just those areas, to include the pneumothorax one that we looked at earlier under the pneumothorax section, right? The Sky Ocean Beach or barcode sign. That's what I need you guys to be able to pull out. Questions on the EFAS for this course? Yes? Shouldn't matter. Abnormal or normal shouldn't matter, right? Whether I tell you it's right upper quadrant or left, I mean, I'd have to look at it and I think I do if I have one of these questions. This is a classic 5 answers that are pictures type question if I have one, right? Because I can give you 4 normals and 1 abnormal and say pick it out. But in reality, whether it's the liver, the spleen, the right upper, or left upper, the abnormal is the same. They're either touching or they're not, right? So for this course, I need you to identify the abnormal, right? I'm not gonna, because the only benefit to that would be like, well, what organ is damaged? Well, just because there's fluid there doesn't mean I know the spleen's damaged or the liver's damaged. That fluid could be coming from anywhere. It just happens to be settling in the right upper or left upper quadrant area with that patient lying supine. Who knows where the bleeding's actually coming from? We don't know that, right? So for the exam, I think I do, but it won't affect your ability to answer the question. Yeah. Other questions on that? Okay, let's talk about COPD, some foreign bodies, blebs, bullae, cyst cavities, all that kind of stuff. All right, COPD, chronic airflow obstruction, irreversibility distinguishes COPD from asthma. More of a pulmonology type thing, right? So for this, we're just going to call it COPD, right? Emphysema, asthma, whatever, chronic obstructive pulmonary disorder. What you're going to learn in pulmonology is they look exactly the same on X-ray in a way, but you can do a certain test and it will tell you if it's asthma versus COPD, but you'll learn that later. Used to have this like blue bloater, pink puffer type thing. They've kind of gone away from that a little bit because they started to find it wasn't as definitive as it used to be when they first put it in the medical books, right? But I'm not going to make you distinguish between these two things. It's more pulmonology. You're going to see what I'm going to ask you to pull out from COPD. What are my symptoms? Dyspnea at rest or dyspnea on exertion? Fantastic. Just dyspnea. All right. Chronic cough with or without sputum? Wonderful. Wheezing? Wonderful. We've talked about all this in other conditions, so there's not a whole lot of the symptoms that are going to help you kind of pull out whether this is a COPD patient. However, this is one of the few ones where you have a differential and we use the imaging as adjunct to help us pull this out. Because we're going to see lung hyperinflation. I'll show you what that looks like. We're going to see a diaphragm flattening. Show you what that looks like. Distal pulmonary vessel tapering, yeah, sure, maybe. Focus on the first two, okay? Kind of like pneumothorax or attention pneumothorax, right? Chronic bronchitis is clinically defined, so understand the clinical aspect here, as a productive cough for more than 3 months in each of 2 successive years, and other causes have been excluded. What does that mean? Chronic bronchitis is a diagnosis of exclusion. You gotta meet that criteria, and everything else has been ruled out, okay? It just means chronic inflammation of the bronchi, right? Is it just because you have that, or is something else causing it? And a lot of times, something else is causing the bronchitis, which is why it's other causes have been excluded, because we got to make sure it's truly just inflammation from no other cause, right? Emphysema is technically pathological, all right, by the enlargement and destruction of the airspace distal to the terminal bronchioles. Those are definitions. You'll learn it more at home. The biggest thing is the chest x-ray. Notice how they're both under COPD, hyperinflation of the lungs, flattening of the diaphragm. You're not really going to use a CT for a lot of this. But here's what it looks like. This picture, I'll have a better picture next. We're going to talk about blebs later on, here in a little bit today, but notice the size of the lungs. The biggest thing I want you to focus in on is look at how long the lungs are. compared to my standard kind of chest x-ray. Okay? This is where we get what's called that barrel-chested patient. The lungs look long, and when you do the whole thorax together, it looks like a big barrel. Not only because the lungs are long, but because we end up with the diaphragm flattening as well. So it looks like a barrel. Right? So look at how long the lungs are. That's my hyperinflation. Right? They're much more inflated than they are the regular. Why is that? Well, part of what's happening with some of the disease processes is you're losing the elasticity of some of the alveoli, so it can't push the air out as well as it used to. So like that's your emphysema aspect, it can't push it out. So the air sits in there, they just kind of get bigger, bigger, bigger. And so now you have more air in the lungs than you do tissue, and so you end up with this hyperinflation. It also looks a little bit darker in the lung fields, okay? So that's part of what's kind of happening with the hyperlucency. Look how much darker this area is compared to these areas, right? Look at how much darker my retrosternal and retrocardiac space is. But also, look at how flat my diaphragm is, okay? You can also end up creating these blebs, which we will look at in a second. But basically what that is that, again, from the emphysema or the COPD type stuff, is they're expanding, they can't contract, they're expanding more, they can't contract, push out all that CO2, but you're still breathing stuff in. So it ends up becoming an issue and ends up thinning out some of the walls of those areas, and you can't really see the lung markings or the vasculature because of all of the air that's kind of sitting in there. And they end up having low tube rates because oxygen absorption doesn't happen well in these blebs or in these boli. They don't happen well because it can't exchange it because there's a lot of CO2 just sitting there that hasn't been expunged. Does the pathophys kind of make sense on a foundational level? Hopefully. Biggest thing, again, is going to be flattening of the diaphragm, barrel-chested, hyperinflation of the lungs, super long lungs, and you're going to have some hyperlucency or increased radiolucency than a normal chest x-ray. This one comes really big into knowing what your normal looks like. So when you look at your patient presentation, you're like, yeah, that could be a lot of different things, right? Great, some sputum or not, with a chronic cough, some dyspnea or maybe not, all this stuff. But then I look at the x-ray and go, oh, that's not normal. Okay, a lot of these patients have a history of smoking, but not all of them, right? Not all of them. Okay, here's another one. These are both COPD patients. See the long barrel-chested? Okay. Any questions on this slide? There it is. No idea. I found the picture. Couldn't figure out why. But if you did your stepwise process, you noticed we're missing a vital organ. That's like maybe.
Hard to see, but there's a case study on this individual that her heart is actually in her stomach.
I would like, I found the picture. I would like you to send me that link in Canvas. No, because I would love to include it.
It was wild. They were like, they took the picture. She like never been to the doctor. Same thing. Got the chest problems. Diagnosed with COPD and the crowd. What the fuck is the heart?
That, yeah. I put it in there because I liked it from a COPD standpoint, and I wanted to see if you guys go through your stepwise process. Somebody goes, excuse me, this is the heart. So those of you who did that, good job. But please send me that link in Canvas because I would love to have the full story on this one. And it was really meant to just test your stepwise process. But do you see the difference in the barrel-chested, the hyperinflation of the lungs, the increased radiolucency or hyperlucency compared to the normal on these slides, right? Probably a smoking patient, doesn't always have to be, but this is going to be your COPD. That's all I need you to know from there, okay? Let's talk about foreign bodies, blebs, belly, cysts, and cavities. This should go pretty quick because we're just pointing out things in different sizes, right? All right, what are those? Anybody know? Without looking at the notes? Magnets. These are magnets. It's a bunch of small magnets, right? Pediatric patient, you can kind of tell by how small the vertebrae are. We haven't really talked about it too much. Look how small the vertebrae are. What do you think they're doing for this patient? No. Surgery. They need to take these out. Because if it was one magnet, they could leave it. But the risk of pediatrics and swallowing multiple magnets is if one gets in one loop of bowel and one gets in the other, and they connect together. And now you cause ischemic bowel disease, and part of that bowel is going to get necrotic, and it's going to die, and it's going to cause issues. So magnets have to be surgically removed if it's more than one, right? But I showed you some of these things to know that not everything on an X-ray is an abnormality from physiological. It's foreign bodies, things that should not be in there. All right? What's this? Bigger magnets? No, not bigger magnets.
Coins.
Ah, coins. Coins. Now the question becomes, where are they at? So here it's easy to tell because they have fallen into the right main bronchus, right? Because I have multiple coins. I have multiple coins in the right main bronchi. And then my lateral is showing them all kind of like looped together in the same area. But if they're up here, how do you know if it's in the trachea or in the esophagus? Right here. I'm not testing you on this, but this will be beneficial in your clinic, FYI. But this will show you, based off of your PA and lateral, because of the way coins get swallowed and what the esophagus has the ability to expand and contract, right? Whereas the trachea doesn't really have that because it's got some cartilage kind of sitting in there, kind of stopping it. This is what it will look like on your PA lateral x-rays to be able to tell you if this coin is in the trachea versus in the esophagus. Now, once it gets down to the main bronchi, all bets are off, right? But you can tell based off of position that these are in the right and left main bronchus. But if they're in the solitary tube that houses the area of both the trachea and the esophagus, this position is how you can tell. What are you doing for a kid that has a coin in the esophagus and the digestive system? Nothing. Just let it pass. Right? Trachea? Yeah, you gotta go and get that out. Coins in the airway not conducive to breathing. That's not a good idea. But if it's in the esophagus, you just let it go. Have mom and dad watch it. You don't need to necessarily do serial x-rays. They tell them, check the poop, watch the poop, right? And then if they don't see it, say, realistically, Dr. Klein will talk about some peds. If it were my kids, I would say like a week, and you still haven't found the coin, then maybe bring them in, maybe do an additional one just to kind of make sure it's gone, because you don't want it to sit in there and rust and cause other issues. But most of these things will pass on their own. You're a nickel for what? I don't even know. Stop swallowing nickels. All right. You can swallow pennies now because they don't make them anymore. So, you hear that? They stopped making pennies? Yeah. They did stop making pennies because it costs 3 cents to make a 1 cent penny. So they finally realized that it's stupid, so they stopped making pennies. So there are no more pennies being made. So, yeah, right. All right, so normal airway anatomy. Right, why is that important? We just talked about why it's important. We can kind of tell what some of those foreign bodies might end up needing. Now we're getting back into how these foreign bodies can cause obstructive atelectasis sometimes, right? So just remember, we can end up having the atelectasis on these patients, more radio opaque. Now I recognize that this patient is a little bit tilted, but this is kind of where we were talking about. There's tilted, and then there's pulling of things. So you kind of see where the trachea is sitting over here, and things are being pulled to one side on the atelectasis. So remember, atelectasis pulls, okay? Pneumothoraces and hydrothoraces push. But foreign bodies can cause obstruction, especially if they're in the airway, which can lead to an atelectasis because we're blocking it, and when we're blocking an airway, it's obstructed, right? Because it's within the airway. If we have something else in there that is compressing the airway, causing atelectasis, that's compressive atelectasis. Numbers are important on this slide. Numbers are important on this slide. Blebs, bullaes, cysts, and cavities. Okay? Because blebs and bullae are the exact same concept, just bigger, numbers are important because you need to know how to diagnose it and call it the right thing. Right? So what is a bleb? A bleb is a small kind of radio opaque area with air filled inside of it. It is less than 1 centimeter in size. Okay? Notice how between the bleb and the bullae, the wall width is the same, so really you just focus on the size. Less than 1 centimeter. Bullae is greater than 1 centimeter. It's the same thing but bigger. Do not ask me what happens if it's exactly 1 centimeter. I don't have an answer for you, which means I'm not going to give you something that's 1 centimeter on the test. It's going to be bigger or smaller. Every class. Well, exactly one. I don't know. Pick one. This is concerning because it can lead to what we briefly talked about in the previous lecture. If they burst, could lead to a pneumo, right? A pneumothorax. We're going to take a look at that on CT, kind of look and see what that looks like. Cysts, okay? Cysts and cavities. There's the wall width there. In reality, you're going to see on image. You can learn the numbers, which I think is important, but unlike the bleb and the bullae, where you really kind of need to have the size of the thing to be able to tell it because they look exactly the same when they're close to that 1 centimeter area, the cysts and the cavity walls are going to look a lot different. The cavity walls are going to look a lot thicker. We've seen some of those already with that cavitary pneumonia compared to the wall of the cyst. So imaging, chest x-ray, you should be able to tell this to be a cyst and a cavity based off what we talk about, the thickness of the walls just from the x-ray. But the blebs and the bullae, you really need to know the size of it in order to figure that out. So, blebs. Look at how small that little guy is. That is very tiny. Can you see it on the x-ray part? Take a look at the x-ray, see if you can find that little bleb on there. I'll give you a second. Those of you who found it are lying because you can't see it, right? So there's a reason, right? So the blebs are so small, they're really hard to see on x-ray, which means if you see these on x-ray, it's probably a bullae, but again, I want you to know the sizes because that is the definitive thing between the bleb and the bullae. So what you can see here is a small bleb, and you see this air on the outside here, right? That's the pneumothorax. It's not from that one, because that one's still sealed off. The odds are he had another one that burst. It kind of looks like it might be right there, right? If you look closely at how that kind of that edge of that lung tissue kind of looks compared to the rest of it, I think that's where it's at. I don't have any way of knowing, but this one's probably going to burst in the near future with the arrow. And so what happens is one of these guys just bursts, and then the air gets out there, and this is what you're calling your spontaneous pneumothorax. Right? This is what happens to your young, healthy guys probably. They get a bleb for some reason, it bursts, they get a small spontaneous pneumo. It's going to self-resolve in a couple of days, likely on its own, right? Likely on its own. You might not even see that pneumo on x-ray. It might only be seen on CT. Now, you can see it on this one, like it's like right there, just to show you. But knowing that these small spontaneous ones, you might not even notice. But that's what a bleb is. It's a less than 1 centimeter kind of bleb. We don't know what to describe. A circular area with air inside of it that can burst and cause a pneumothorax. Whereas the bullae are much larger, greater than 1 centimeter, okay, thin-walled. You can see them nicely on CT like this, or right there on x-ray. Now, don't get tricked. This isn't a pneumothorax, even though there's no lung markings here. Why? Follow my radio-opaque line. It is not in the shape of the thorax. That is a very large bullae, causing the absence of those lung markings because it's just nothing but air, right, expanded out. If it were to go this way, it would be a pneumothorax. But I don't have that. I have this. That is a bullae. Okay, we already kind of talked about in the COPD, same concept here. Having gas exchange in the blood is really, really difficult in these bullaes, which is why they'll end up having low O2 sats and things along those lines. So size is going to be the difference. They can be huge. So the CT shows you that They may not be big, and maybe a bunch of smaller ones, but still bullae because they're greater than a centimeter. Whereas the X-ray is showing you that they can be huge, and there's another one kind of hard to make in there. So you have two big bullae taking up really the whole hemithorax. So they both cause. So here I'm showing you the little blebs, right, and then here I'm showing you the bullae. Size. Blebs often need to be seen on CT. Very rarely are you going to see them on X-ray. Questions on those two? All right. Cysts. All right. So we briefly talked about this with large cell carcinoma, right? So I have my cyst and I have the air fluid levels. I shouldn't have air fluid levels in the lung. The lung shouldn't have any fluid in it. But if I have this nice little compartment, there's one here and there's one here, and I have my air fluid levels, that's a cyst. Okay? And notice how it's flat. It's not the meniscal side because it's in that contained area, right? I don't have the full force coming down. It's just nice air fluid levels. But on top of that, I have the walls of the cyst. Look at how thin that cyst wall is. I'm going to erase the line again. Look right here. Look at how thin that cyst wall is. They're very thin, and they have the air fluid levels, and that's going to be your cyst. Okay? Here's how they look on CT. Now, what do you notice is missing on the yellow circle in the CT? Fluid. Does that mean it's not there? No, I need to scroll down further. The odds are there may be some fluid there, right? So just understand that aspect. If I give you a cyst, it'll be on an X-ray, so you can see the air fluid levels, right? Because CTs, it really is dependent on the slice, and I can't give you multiple slices on the exam, unfortunately. So there's no way for me to do that. But,
Sir?
Yeah.
For this instance, if this patient's laying down and there is fluid in there, wouldn't it be constant for the CT?
depends how much fluid, right? It depends how much. If it was something like this one, then yeah, I would expect to see a small line kind of right in here, right? But how much fluid is actually there, I don't know. I mean, could this right there be a very small amount of fluid sitting down there? It is a little more radio opaque, I don't know. It's hard, and with one slice, I can't expect you to figure that out, right? If I had a whole CT, I can scroll through it, but can't do that on PowerPoint. That's the only way we know how to teach PAs. It's PowerPoint, okay? So that's what I got to deal with. And we're limited by med. All right, cavities. Look at how much thicker the walls of my cavities are, right? And on top of that, I typically don't have a whole lot of air fluid levels in there, all right? But if I had like an abscess, I would have some. But really, I want you to focus on, look at the thickness of the cavitary walls. 3 millimeters to several centimeters. These things can be thick. Most commonly seen in tuberculosis because we want to wall it off. The body wants to wall it off to prevent it from infecting others, infecting the rest of the body. So cavities have that thicker parenchyma, that thicker wall between the cysts. Not always their fluid levels, but it's really the thickness. So if you're looking at those two things, use the wall thickness between the images and the CT and the size to figure out, is this a cavity or is this a cyst? Okay? Questions on that? Bronchiectasis. A lot of words on this slide. Okay? A lot of words on this slide. Look at all the symptoms. There's one that really stands out. Okay? And that's the productive cough. And not because it's productive. Copious amounts of sputum. What is copious? 200 to 500 milliliters a day. That's a lot of freaking sputum, right? Not only that, it's thick, purulent, and foul smelling. This stuff smells like something died in their lungs and they're coughing it up. It is miserable. And they'll bring it in, right? Because it's that bad. It's one of those things where they're like, I'm gonna go to the doc, they need to see this. And they'll be like, yeah, here's what I'm coughing up. And you're like, who collects their sputum? They'll do it. They will do it, right? And not only that, they'll probably have some hemolysis with it as well, okay? But it's the copious amounts of sputum that is one of the things that should make you think about this. Go further down, halitosis makes sense. Why am I having halitosis? Because the sputum smells so bad, right? Hey doc, yeah, I've been coughing up a lot of stuff, but my breath just reeks. Like no matter how much I brush my teeth and use mouthwash, it's like I do nothing. Like it's just always is just terrible. I can feel it, I can smell it, I can taste it. Unfortunately, they'll say that, that kind of thing. So what causes it? Usually recurrent infections, sometimes some immunological disorders, rheumatological disorders, cystic fibrosis maybe. Biggest thing, chest x-ray is going to be your initial study, okay? Shocker, often normal. Yeah, right? But when you have this patient and the chest x-ray is normal, you're going to get a CT scan. Because we know now that we're learning this, we know that the chest x-ray is often normal. We still do it as the initial study because, yeah, sure, it might be bronchiectasis, but it might be something else. So we're going to get the chest x-ray, evaluate it, see that it's normal potentially. Maybe I see some cystic lesions, maybe not. But then I'm going to get my CT scan study of choice, right? Because then I'm going to see my airways are filled with mucus, and I'm going to see that signet ring sign, okay? So what does that look like, and what is that? You get the honeycombing from the thickened bronchial walls, right? Looks like a bee's nest, looks like a honeycombing, which you can only see on CT, okay? So first we get that honeycombing. We have the thickened bronchial walls right here. That's what this is showing. The thickened bronchial walls, all right? And the honeycombing. What we're also going to end up seeing is what's called a signet ring sign. So I have my bronchioles and the pulmonary artery, right? So it's like a ring and a pearl, right? That's what that is. It's showing you the ring and a pearl on the end. The pearl is not the abnormality. The pearl is the vessel. The abnormality is the thickened bronchial wall that causes the ring that makes it really stand out on a CT scan, right? And so that's the abnormality. This is just the pulmonary artery. So signet ring sign. If you notice over here on my normal, right, I can see the vessels, I can see the pulmonary arteries, I can see all of those, right? But I don't have the ring attached to it, I just have the pearl. That's normal. If I have a ring attached to it, that's my signet ring sign, that's my bronchiectasis. And that's why we do a CT as a study of choice to truly diagnose this, because look at the kind of detail I need to be able to find that, right? So you get that patient with those symptoms, chest x-rays, we do the initial study, normal, and then you turn around and you go and get the CT and we'll show you that. Here are some x-ray findings. It's in the book, right? Sure, great. Look at my tram tracking, right? Can you see that? Yeah? No? See the ring sign right there? No? Yeah. That's why CT is a study of choice, right? You can see this x-ray and go, and with the patient's symptoms, right? Patient symptoms should be enough for you to suspect bronchiectasis, right? You don't even need the image if the patient is coming in with this kind of stuff, right? And maybe has some history of here, okay, to suspect bronchiectasis. But if you wanted to do the image, the initial study is going to be an x-ray, the study of choice is going to be a CT. I put in there for you guys, I'm not going to test on bugs, but here's your most common things that are causing it, staph and Klebsiella. So that way when you get to the point where you're treating folks, you know what antibiotics to go after, try to treat them, okay? But yeah, that's what that's going to look like. Okay, white arrow. Of the four things we talked about, plebs, bullies, cysts, and cavities, what would you call this one?
Appendicitis.
All right, and if you said cavity, good. Look at the thickened walls. How thick that wall is around there, blocking that off. So that is a cavity. What's this?
CT.
Just talked about it. Honeycombing, right? Could that be a bunch of plebs, maybe? Sure, maybe. right? They're not super thin, but again, I would give you a patient vignette with this to help you understand what we're trying to look for and what's going on. What's that guy? That is a large cyst. How do I know it's a cyst and not a large cell carcinoma? Look, I got air fluid levels. Air fluid levels right over here. So that is just one really big cyst. I believe I put in the notes. This is from the British Journal of Medical Practitioners. It's a complicated pediatric bronchogenic cyst complicated by atypical mycobacterium infection. Large cyst. Largest one I've seen on imaging, so that's why I put it in there. To show you that the difference between that large cell carcinoma and that cyst is going to be that air fluid level. All right. Mediastinal stuff. We're going to go through this pretty quick, and you're going to see why we're going to go through this pretty quick. This is stuff that I need you to understand and kind of know from a generality standpoint, but from what I'm about to break down for this course, put it in your head pretty straightforward, right? We're going to define the sections of anterior, middle, and posterior masses within the mediastinum. Okay? You divide the chest. There's words, right? I'm not going to read that to you because I have a picture right here which shows you. Okay? Anterior mediastinum, medial mediastinum, and posterior mediastinum. If you have a mass in the mediastinum, you're probably going to jump to a CT because it's more accurate in determining that. Here's what I need you to know. What is in which one? Look at this. Middle mass is lymphadenopathy. Posterior mass is neurogenic tumors. There's one in each category, guys. The rest are anterior or superior. So, if there was a question, I have not made the test yet, I don't know, but if there was a question asking you which one of these is a middle mediastinal mass, and I give you the 4 anteriors and the 1 middle, right? So basically what I'm saying is, remember these two, know them all, but as far as memorizing like what's in each section, if you memorize what the middle one is and what the posterior one is, then anything else is going to be anterior or superior, right? As far as from test-taking strategy standpoint. We're going to look at some of these, but really that's what I need you to kind of pull out now, right? Because you have to differentiate between a mediastinal mass and a parenchymal mass on chest x-ray. If you're going to do that, is it surrounded by lung tissue? If it is, then it's probably parenchymal. If it's not, then it's probably within the mediastinum, right? CT is going to be more accurate in determining the location than conventional radiographs. So it's going to be another one of those things. If I see a mass, and we talked about it already, we see a mass, we don't know what the mass is, what are we doing? CT. If I want to know a study of choice to figure out what the heck the mass is, where it is, what it is, it's going to be a CT. Okay. So just showing you some of these things, so you've seen them before, right? And I'll point out the things that I need you to know, that I want you to know for these sections. So the first thing is going to be your thyroid mass. Okay, here's my normal. I can't really make out my trachea. Why can't I make out my trachea that well? Because I have this large thyroid mass that's sitting right there. What's my study of choice when I'm concerned about a thyroid mass? Radioisotope thyroid scan, thyroid scintigraphy, right? Ultrasound is going to be that initial study for the thyroid, but the study of choice is going to be that thyroid scintigraphy. Bless you. Okay. All right, here's what it looks like. They had a CT done, right? And again, that's what, I want to be clear, because I heard some people say CT. And this is when you know it's a thyroid mass, right? So you were right, you said CT. If I have a mass and I don't know what it is, the CT is the study of choice to figure out what that mass is. But if I know it's a thyroid mass, then for that thyroid, it's that scintigraphy to further evaluate it. Does that make sure that's clear? Right? And the reason I can say scintigraphy is because I'm telling you here, it's a thyroid mass. That's why the study of choice is scintigraphy. But if I did not know it was a thyroid mass, then yes, we need to be doing a CT to further evaluate this mediastinal mass and figure out what it is. Because we have the CT here, there it is, showing you that we have this large goiter, that's T for trachea, not T for thyroid, there's air in it, right? So we have this large goiter sitting on the thyroid, okay, has some calcifications, right? That's kind of what that looks like. And then again, that tells me nothing except for the fact that it's a thyroid mass. The radiologist will be able to tell you that, be like, hey, it's attached to the thyroid, and then you jump to the next step to be able to further evaluate that. Lymphoma, okay? Chest x-ray finds the mass, CT study better defines the mass. Cross off, that's what I need you to know. Cross off this lymphadenopathy crud, because I need to fix that. Because it's very confusing that I have lymphadenopathy, which is your middle mediastinal mass being talked about in an anterior mass section about lymphoma. So that's on me. I will not, any of this information from lymphadenopathy down is not going to be testable because it's very confusing. So just cross that off from your study points. You'll learn more about this when you get into endo, when you get into hem-onc and stuff like that. Thymoma, typically pediatrics, okay? Because we have the large thymus gland, normal in children. Pediatrics has one, but then as we get older, it's supposed to go away. They're benign. If it doesn't go away, I think it's like middle age is different now. I don't like that word. You should be more concerned if you're 25 or older and there's swelling in the thymus gland, be concerned about a thymoma. Don't use middle age because like middle age now is like 50s, right? Because people are living to like 90, 100. They just changed it. You should be finding this way before 50s. This should be like a mid-20s to upper 20s type thing. The problem is, a lot of times it's going to be incidental because they're asymptomatic, they're usually benign, they don't really come in a lot for things. You'll get a chest x-ray because they come in for a cold, you'll see this giant mass, you'll get a CT, and then they'll figure out it's a thymoma, and then it'll be up to the specialist if they want to do anything about it or not. Because they're benign masses, it's not a cancer or anything along those lines usually. Teratoma. Anybody know what that is? You ever hear that? These things are gnarly. These things are so gnarly, right? So teratoma, they're benign, right? They're benign most of the time. 30% of these guys are malignant, so they just go in and they take them out. It's germ cell layers, right? It's extra growth of different tissue. It's the last slide we'll do. So when they take these things out, they have hair, they have teeth sometimes, because it's all the germ cells you have in your body and it just started to grow. This was like the joke before, they were like, oh, you were supposed to be a Siamese twin, but the other twin didn't form. That's where this joke came from, was when they would take out teratomas. That's not actually true. It's not an actual another person that was supposed to grow with you. That's not accurate, right? It's just overgrowth of germ cell layers, the ecto, meso, and endoderm, that weren't supposed to happen. And so they gotta go in and they take it out. And it's got all kinds of stuff in it. But even though most are benign, because 30% is not a small number, right? 30% of these are malignant, they just go in and they remove it. So the CT further assesses the mass, they find out that it's a teratoma, and then they get rid of it, okay? We'll talk about these last ones on the next one. We only got about 8 slides to go, and again, it's just showing you what they look like on image, so you kind of know what areas they're in, but it'll be pretty quick to go through that. Any questions for today? This is the end of the test, minus these like 4 or 5 little slides. So we have 2 slideshows left of abdomen, and then that's it. So, all right, I will see you guys not tomorrow, in the future. I'll work with your class there.
Real quick before everyone takes off,